We'll move on to our next session, which is a panel discussion on the need of physical medicine and rehabilitation in undergraduate medical curriculum and in clinical care practice. I'd like to invite on stage the moderator for this session, Dr. Shopon Misra sir.
Our in this panel discussion, as you have said, seen that this already our DME sir has been elaborately said about the need of the PMR in clinical care practice, and also Dr. Sardar has said about undergraduate curriculum inclusion. So I will call Professor Indrajit Saha sir to stage as one of the panelists to say a few words. I will ask questions. Professor Bandyopadhyay, sir. Dr. Indrajit Sardar sir and Dr. Sankar Sinha sir. Before going into the topic, I must say that this program is basically designed to integrate rehab in every clinical care practices, because this is the need of the situation, and there is huge number of chronic clinical conditions which are needing rehab services, particularly in the low socioeconomic condition countries. And I will go two documents which are very important before starting the panel discussions. WHO has published a couple of days ago and available in public domain. One is Rehabilitation in Health System, another is Rehabilitation 2030 Call for Action. And facts of figure of these documents, if we go through, is a huge document around 140 pages. And WHO feels that rehab is an essential service to anyone, whether acute, whether chronic, whether impairment, whether injury, which limits function of a person. And it is crucial to achieve universal health coverage and sustainable development goal. It addresses limitations in everyday function due to aging, chronic disease, injury, trauma, and makes them remain independent, most important, whether in society, whether in education, work, with a meaningful role in life, not a vegetative life. But there are challenges: underfunding, lack of trained rehab professionals, very crisis, poor integration. Most important is inadequate integration between the clinical services and rehab, which limits the, especially the low resource country.
I would like to make it a bit interactive. So, how many of you go through economics? Okay, I don't go. I raise my hand first. So, doctors, those who are not interested in shares, equities, they might not go through economic times. But every time I board a Shatabdi or Vande Bharat, or every time I board a flight, I ask for the economic times, just for one reason, that I just want to know if there is any recent article, not based on the standard textbooks, which are of course 3 to 4 years old, that whether there is any stats regarding the age-wise population distribution, which we familiarly call as the age pyramid. Still, if we go through the age pyramid of India, we expect what we have read earlier, that it is like a pyramidal structure with a broad base. As our growth rate is still high, the birth rate is more than the death rate, and we are pushing in new individuals in our population base as compared to the persons, which crudely saying, as compared to the persons who perish. So our population is still increasing. Though the rate of increase has diminished, but it is expected by 2040 we will reach a stage where our population will attain what we call a population stabilization. Now, why did I spend so much time on this? Because once we reach the phase of population stabilization, that pyramidal structure, sirs and madam, will vanish within the next 10 years. It will turn more into a cylindrical structure with certain fatness in the belly. More or less, I don't know how to describe the shape. It will be thinner in the top, a bit thicker in the bottom, but fatter in the middle part. And gradually that middle part will rise to the top part. That means it will rise to the geriatric age group. That means, in summary, the proportion of geriatric aged population will increase, and which has a very long-term implication. As we know, these degenerative diseases, these degenerative diseases, these chronic diseases, which all our speakers have been saying, this emotional solitude, as people go old, they are basically, whether we agree or disagree, it is a totally different thing. As we get out of service, our workplace eliminates us from the system. As we attain age where we are no longer productive, maybe our family thinks that we might be redundant. And at a particular, when we even grow more older, a stage will come when the society will eliminate them. And people think that even if I die, my photo will be there, people will remember me, okay, this was a good man, or this was a bad man, or this was an ugly man. Okay, people will remember me. But the basic fact is that people won't remember you. The sands of time will cover you in the dust. But the growing need, which Professor Mishra was telling, that our geriatric age group is increasing, because India is a country of 140 crores. And even if we tell that the geriatric population base might increase to 10%, that means, sirs and ma'ams, you have to deal with 14 crores of people who need rehab. And so, an undergraduate medical student who does not know anything about rehabilitation, who does not know anything about PMR, because PMR is not physiotherapy, ma'am. PMR is not physiotherapy, sir. In our younger days, whenever we encountered such a problem, we used to write in the ticket, refer to physical medicine, refer to PMR, refer to physiotherapist, all this rubbish. But an undergraduate medical student must know the domain of rehabilitation, that what are the areas to be covered under rehabilitation, and what are the basic tenets of rehabilitation. I am not going into the microscopic details now, that what topics are to be covered, what issues are to be covered. That will, of course, come out from the deliberations of the other speakers and the interactions from you and the questions which come from you. But whether the National Medical Commission feels it right now or they don't feel it right now, but a time will come when the National Medical Commission will definitely include physical medicine and rehabilitation as a compulsory subject in the UGME or undergraduate medical curriculum, because of the changing societal needs. The Medical Commission, the National Medical Commission, is committed to make amendments in the medical curriculum so that it is competency based and it addresses the societal needs of the country, as also the economic constraints, given the economic constraints. For my opening statement, this much for now.
Sir, I already said about this NMC issue, so it was my next question to you, sir. In 2019, there was CBME published by the then MCI. Now it is NMC. So it was there in essential subject, but in amendment 2023 MSR, they have removed it. So how do you suggest us to pursue?
So the National Medical Commission, if we see the composition of the National Medical Commission, they are all senior professors and renowned and eminent medical practitioners, medical professionals from different disciplines. And so far I know, there is only one non-medical person, Raghav Langar, who is an IAS officer, and he is the secretary of the National Medical Commission, and he does the secretarial work. And sir, so National Medical Commission is for the doctors, by the doctors, of the doctors. And I wish that they will recognize the societal need of the increasing requirement of rehabilitation for the entire society, given the number of people who need it. And I was just going through Google the components of SDG, the Sustainable Development Goal. The rate at which we progressed in the last 5 years is not as we progressed earlier. So the rate of progress has a bit declined. We have taken a hit, but I think we will fight back. Because during that period, COVID was there. During the last 5 years, COVID was there, and we suffered a few setbacks, but that not any excuse. Because having regards to the Sustainable Development Goal and the Universal Health Coverage Package, UHC package, maybe it is too much wishful to think that we will integrate this right now at the primary healthcare level, but it should be done. And I think the way the National Medical Commission is reforming the curriculum, I think as radiation oncology has been included, because last time we gave our annual disclosure report, we included the medical oncologist, and I think PMR will come. And when I was the principal, just a few months back before joining this post, I mandatorily requested my faculties of PMR to fill up their declaration forms, and they were very happy because it was first time someone was asking them to fill up the annual declaration forms to be submitted, to be uploaded in the National Medical Commission portal. So this is my personal view that National Medical Commission should include physical medicine and rehabilitation as a part of the UG curriculum.
So with this next...
Professor Manoj Bandyopadhyay will add something.
With the kind permission from DME sir, I like to comment something on this particular point, that why it was removed. Actually, in the their curriculum 2019, it was written. It was there are some competencies were clearly designated for PMR, but later on it was not rescheduled, rather not removed. I should not say that it is reduced. It is rescheduled. And probably one point is that as I was in some new medical colleges, and I was also developing the colleges from 2019, 21 and 2023, that there is maybe some lack of faculties. So that may be the reason why they have withheld the compulsion of including PMR in the new curriculum. It may be one point, but more and more faculties will be recruited. I think it will come.
Okay. So that's why my next point was there is lack of rehab workforce, and most important is underfunding. Underfunding is very important in rehab, particularly infrastructure development. If you see in West Bengal, all the medical college rehab department is not equally developed. Whether intake, whether appointment, whether SR deployment, there are some misplanning. SR may be posted somewhere there is nothing to do, or there are departments do not have SR. So I think we can reconsider about the posting of or intake of workforce in a better way. How we can think of it?
Sir, I absolutely agree on your proposition, sir. The thing is that the way we deploy the SR since the last 3 years, because this compulsory bond service, indemnity bond service, for 3 years, I think it was introduced 21 in the year 21 or 22. Because previously there was only 1 year of indemnity bond. But as soon as this 3 years indemnity bond protocol was introduced, there was a system of merit-based counseling. Merit-based counseling means depending on the demands given by the principal, we used to open the seat matrix for the senior residents, for the prospective senior residents, I'm sorry, and the persons who have passed their MD or MS or DNB qualifications, they used to fill up those choices, and based on their choice fill up and the seat matrix, we used to post them. They used to get a posting in the medical colleges or in the health facilities they chose. But now, as you are saying, I fully agree with you. It should not be like that. That it should not depend on the choices of the prospective senior residents, but it should depend on the departmental needs. That what the department needs, what the health department needs, what the society needs. It should be based on that and not merely on a system of merit-based counseling. I know whatever I am telling is it is very cryptic for the persons who are not in our system. But if I get time, I will explain it to you later, ma'am. But there is a system in place of now that I don't claim the system is 100% okay, but still some system is there, and that system needs to be revised according to the departmental needs. That we need to open up more seats in the seat matrix which we publish in such places where rehab facilities are there, where there is a scope of work, and not blindly based on the choice of the choice of the applicants and the demand of the locality. Because people might ask that give me an SR of PMR, but I do not have any work to give him. That is also not fair. Let's see, sir.
Thank you, sir, very much.
Sir, in
So,
future we will try to correct ourselves, sir.
we have
Thank
full
you.
confidence on you, sir. So, going to Dr. Manos Bandyopadhyay, how to attract UG to realize the need of PMR in UG implementation? How to attract? How to create attract them? Your idea?
Attract the students. Actually, there are no such data. Only one study I found that where the observer he did a one cloud-based study in among the medical professionals. So how they are accustomed with the need of PMR. So they found in the initial stage of the study at they hypothesized that most of the professionals are not accomplished with this PMR, but they found that at least 95% or more professionals, they know what is PMR, and they also agreed that subjects that they found the terms of PMR during their medical school or their teachings. So they are knowing what is PMR, most of the students nowadays. Not in our days. Our days we are just only knew that there is a department called physical medicine or physiotherapy. So we used to refer the patient for physiotherapy or physical medicine. Now the student know that there are departments, but problem is that in medical council they somehow they first in earlier days they made some competencies with some knowledge domain, with some affective domain, with some skill domain, but they have now not very much they made them in the optional stage. That is not compulsory, that is not core competency. So that is why the students are not so much habituated to go to the PMR. But when they are studying in the different subjects in the course of their curriculum, in every subject the teacher emphasizes the need of PMR during their course of study. And we generally what we do in our colleges, there are some clinical attachments. So when they can go to the PMR, we have some foundation courses where we can give them some ideas of PMRs, and we also during the internship they have been given some duration to spend hours in the PMR department, where that faculties in PMR, they sensitize them. So this is how they try to attract the UG medical students, and obviously they know that there is a growing up pediatrics age group, increasing in the chronic diseases. So they must be ended with the ultimate treatment like with PMR.
Okay.
So this is
So next point is, as a member of medical community, do you feel that common people also do not have any idea about this, that how they can be benefited by getting the service of rehab,
that common
their quality
people,
of life and all?
awareness of common people. But the question is very interesting, that I want to share one experience, my experience. And few days back, one of my brother suddenly meet in some places and ask me, যে মানুষদা তোমাদের কলেজে কি PMR ডিপার্টমেন্ট আছে? He knows very well me, and I am posted in medical RGCor Medical College. So the first question is that he is not aware that physical medicine department is there in the medical college. আর কেন জিজ্ঞেস করছো? না আমার মাকে দেখাবো। আর তোমার মাকে ফিজিক্যাল মেডিসিনে কে দেখাতে বলেছে, মানে কি হয়েছে? না আমাকে আমার মায়ের কেউ একজন বলেছেন যে কোমরে ব্যথা, ওটা ফিজিক্যাল মেডিসিনে দেখাতে হবে। সো দ্যাট অলসো denotes that they are sensitized with physical medicine, because in low back pain they have to go to PMR. So this is now there is increased trend of awareness among the general people regarding the PMR. So it will be going up as they will know that there is a patient with cardiovascular disease, pulmonary disease, neuromuscular disease. So all will end up with their physical medicine care.
Okay. Currently, under CRMI, Compulsory Rotatory Medical Internship Program, NMC has, earlier it was more days, now it has been only 4 half days schedule. 4 into half, not that 4 and half. And that also with ortho. So what happened in our experience?
Actually,
sometimes they came, sometimes they do not came, because sometimes the completion certificate in this university book,
that is a
separate
real,
department not mentioned.
that is a real maze and problem.
So do you think this is enough?
That is a real problem I regularly face with my faculties in orthopedics and PMR. They are often regularly comes to me how we can give the completion certificate, and there is no fixed hour for PMR training in present NMC curriculum. That must be that is included in the broad specialties, no other separate specialty. Probably the NMC person, they thought that it should be just IMG should only know the basic principles of PMR. They do not require any such special classes. So what is this question?
4.5 days. Is it enough for training?
No, this is not enough for the training.
Okay, so how can we pursue? What can we do?
We in our setup, we always recommend, we always ask our faculties of PMR and orthopedics, you give them much more broad teaching schedule or like that, and also foundation course is there. So this is how we can manage some of these cases.
So we are moving to Indrajit Sardar sir. We have observed a section of clinician, as DME sir already talking about earlier, that they are preferred to send to PT instead of sending to PMR, though department is there.
Thank
So
you, Shobhan.
it's a perception.
The thing I want to emphasize is that you have to look from the medical student's point of view also.
Yeah.
I mean, why should he go to PMR? Why should he go and pursue his course later on life in PMR? And the reason is you have to make the PMR things attractive also.
Yeah.
And the attractive part of it is that you're dealing with disabled persons or differently enabled persons, and then trying to restore them as much as possible. In that aspect, you're restoring their families also. But for a young medical student, he needs to find in PMR something which will also help him in his future career and life. In which case, I think one of the great areas in which to explore is sports medicine. Sports medicine is a part of PMR also. Yes. And sports medicine is very attractive nowadays. And if you decide that this is the region where they want to go to also, that will attract more persons. And the more persons you have, the more postgraduates you will have, the more teachers you will have, the more workforce you will have who will come to this area. Young people willing to sacrifice their entire careers for this. It is not an easy choice.
We are actually. So, no, my question is referral. They are referring not to PMR, to clinicians. They know the department, but they are referring to PT, not to PMR. So, what is
Yes.
the
What you
question.
need is also a task force for teachers.
Okay.
So you need teachers
So-
also who will attract people to come there.
Do you have any personal experience getting benefited by referring, by involving in your clinical practice, PMR team or rehab?
Yes, of course. When we talk to certain persons in PMR, there is this aspect that they can also help in many aspects of making this attractive to the students to pursue a career in this and to make a lifetime of this also.
Okay. So, my next question will be, we claim that we feel and there are guidelines that day 0 should be the involvement time for PMR in any clinical condition, WHO also. What is your idea? It is right claim or?
I think it will be easier for us to refer patients who need a rehabilitative seriousness rehabilitation program. They do not have to be handicapped or differently enabled in future also.
Okay.
But certain things that they can come back to as useful members of society also.
Now, should
And
we
for that
involve
you need a
in
reference
from
to
first
PMR.
day of any clinical condition, from first day we should involve or not?
Yes, you should.
We should.
We
Okay.
involve physiotherapists as such, but they are not everything.
Okay. That's the,
They are only a part of the whole program.
okay.
So you need people to go into a program in which physical medicine persons are involved and therefore get back to a more better way of life.
Okay. So coming to finally our pediatrist panelist, you are couple of decades one of the senior most member of the pediatrist community in our city. And what do you feel about need of PMR in clinical care?
You see, when a patient gets admitted in the hospital in a moribund condition, what the relatives want actually, first they want life, then they want consciousness, then they want comprehension, and finally they want কবে হাঁটতে পারবে, কি করে হাঁটতে পারবে, নিজের কাজ নিজে করতে পারবে কি, আমাকে কি ওর পেছনে লোক রাখতে হবে? So this final part is rehabilitation to get the relief from pain, to regain the mobility, to regain the self-help activities. So there is enough reason of knowing PMR in undergraduate course so that the medical persons who are not really PMR later, they can learn how to use the PMR specialty for the betterment of the society, for the economical viability and better utilization of family people workforce.
There are awareness issue as we have already discussed. How can we overcome?
I think it is awareness of the clinicians. If I am permitted to say, just give figures. PMR department first opened in SSKM Hospital in 1957. Physiotherapy course had started in 1964. PMR MD course started in 1979. Throughout these years and even today, something is being done for the patients, and the orthopedic surgeon and physiotherapy, these are going on from 60s or 70s like that. They went on. Gradually, in this way, the physiotherapy and rehabilitation are being used synonymously for decades together. This is the point where clinicians do not understand what is physiotherapy and what is rehabilitation. That is our mistake, that we could not be proactive to teach the clinicians for generations what rehab is and how physiotherapy is a part of it only. So thing is that what we can do, that we cannot teach the clinicians, we can do conferences, and the next thing for future generations, the inclusion of PMR in curriculum is made more than mandatory.
So about 4.5 days, so you have already discussed. So what are challenges you faced, because you are in a corporate, ROI is the issue. So how can you, what challenges you face to develop a department? Because you are department.
Just in a single sentence, I would have something to say about that 4.5 days.
Okay.
That in this year at my department, of the total referrals at Indore, 27% was related to orthopedics, 31% was related to neurology, and 42% was for other specialties. So it is not only orthopedic cases, but there are lots and lots more cases for which one PMR person should be apprised actually. So 4.5 day or 4 into half day,
4 into half.
it is less.
2 days actually.
It should be less. It is less than negligible.
That's. So what about challenges that I asked in how to develop, where in a corporate developing the PMR department?
Before 93, Calcutta Hospital has got physiotherapy department. But Peerless Hospital is the first corporate hospital where PMR department has been opened, and I could do it. The primary and first challenge was acceptance of the term PMR. The authorities were not accepting. They have written that Department of Physiotherapy. So I had to change it, and I had to spend some time to change the term. Second one, all the consultants have come from abroad. They are not really well acquainted about the rehabilitation. So there had to do some one-to-one consultation, one-to-one correspondence with the consultant so that they can start using my data.
Finally, my final question will be to you that how you advise to young physiatrists for their career growth and rehab department service, etc.
I'm very simple on this answer. If you can recall what these two gentlemen has told, that there should be some societal need for the rehab. You see, no particular specialty will help you go. Not orthopedics, not neurology, not cardiothoracic surgery. In a corporate hospital like ours, they always want to keep the spotlight on them only. So they will not help you to grow. You have to grow. How? Number one, you have to document your work. You have to be interactive with every patient party. You have to show your presence. You have to make your presence viable so that you are doing something for their patient, and that should be recorded everywhere. In this way, each and every societal component will get aroused that this is required. So we will go to PMR. Then only you can see that every back pain need not go to orthopedics. Every headache, every shoulder pain should not go neurology, like that. It is just roughly. So they will know where to go privately.
Okay. So my final slide to audience, any one or two comment or question if you have, otherwise we conclude.
Thank you, Professor Prasad. First of all, because of fantastic such a nice, creative session. I was actually waiting. I was supposed to go for the another session. So still I waited because so many luminaries will be there in this particular session. Very beloved, our DME sir. Actually, I'm telling him, sir, because of his particular share, he's like any other brother. It was very close to my heart, and still he is very close to me. And also, Dr. Professor Sardar was associated with me long time back in IPT when he just did the IPE. And Prasad, I think Dr. Sinha was the colleague he shared the sessions. And actually, Professor Bandyopadhyay probably do not know me directly because Pachumar was my student. Yeah, I know that he is a classmate. And now the antibodies in the full swing, especially the diabetes kids are the other species concerned. So this is the reason I stayed here. And I have learned a lot from what you have to do. I personally feel that when I was a student, I passed in 1975. So when we were the students at that point of time, the concept of this PMR was not there. And we was not at all there. So gradually what you have told, that we developed like a very small thing and it is developed. Today you see, you will understand that this rehab this particular name itself signifies that in future, definitely it's got a future. And I do appreciate it should be included in undergraduate. It must have a postgraduate course. And there should be more amount of involvement of the BDS. Because the people has not yet been fully aware of what is happening. We cannot do something in isolation. What I mean to say that our duty is to take care of our neighbors. Because health is a state of complete mental, physical and social well-being. And not merely the absence of disease or an infirmity. It also includes the fourth dimension, that is the spiritual aspect of the health. So I think in your neighbors and other people, you have to take everything into consideration. That's why I will request our DME sir and other, if possible, from the government side also, you try to include the public, media and other things so that this particular subspecialty gets its benefit and in long run, ultimately the people will benefit. Thank you very much, sir.
Thank you. We are concluding, so we are already the end of time. Sudhir, thank you.
From the very day of admission, the need of rehabilitation, how to make the position free. And in case of spinal injury, I will keep the foot in the plantar position, right? Just like this. And in the EMS, when I was student, they used to do like, say, in undergraduate, spinal injury case was in class for neurologist and neurosurgeon. They came and give the lecture how to manage.
Okay, sir. Thank you, sir. Thank you. We'll continue. Thank you. Please.
Just before Professor Mishra concludes, one thing for you, sir, that whenever National Medical Commission makes any change, the draft document, that means the draft minimum standard requirement or the draft DEQ is
Available.
put in the
Website.
National Medical Commission website for at least a period of 3 months for all of us to comment.
Right.
But as we know, due to our inertia of not doing anything, inertia of remaining in the status quo state, we don't do anything. We just go through it and okay. Please.
Thank you.
Can I just one? Sir, I am Dr. Manisha Jaiswal. I am a pain and palliative care physician. So as a panelist said that we can develop this department only with the help of the society and if there is a need in the society. But what I feel that society really needs, and there is a need, but the problem is that the society does not know the difference between a physiotherapist and PMR physician.
Yeah.
So how do you overcome that problem? Because most of the physiotherapists, they call themselves doctors, and patients, even before going to the orthopedics or coming to the pain physician, they go to the physiotherapist and get themselves treated. So how can you overcome this problem?
Listen to whom?
They just do a 6 months course and they become doctors.
Asking to which panelist?
Anyone, sir. Anyone can.
See, it is a real problem everywhere. You cannot teach the whole society that who is who. You cannot teach because there is no rule from government level or anywhere that the physiotherapist should be only under directions of physiatrists, or they cannot write doctors. There is no stricture upon them. They use as they can. And
Should there not be a rule that they cannot write doctors?
there should be rule and there
No, there is actually, see, it is a separate topic altogether. Recent act has been published, okay, Commission for Allied Health Professionals. They have allowed to write doctor by prefix, PT by suffix, before and after their name.
Then
So
this
that's when they have started writing more. So that is altogether different discussion. This is not our part of discussion. Our part is only
তুমি কোথা থেকে বললে কথাটা কি কি করে হয়েছে?
commission, not new act has been published,
আচ্ছা,
which allowed them to write this. They may write
What?
provided they have bachelor degree or master degree, not diploma. That is the thing. So that is the reason why they are now more and more right. So that is altogether different issue. So we conclude because we are already ahead of schedule. Thank you all panelists, particularly our DME sir and our principal sir and Dr. Indrajit Sardar sir. Thank you.